The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan, and we want to welcome you all to our Safe and Calm webinar for September 30. Last night, the governor again extended the state of emergency to October 29th, which we would have expected. And in general, cases are going up a bit again here in Michigan and across the country. And the number of directives and executive orders keep rising as well. And we hope to be able to assist you in managing all this continuously changing information. This morning, before we begin, we also want to let you know that there will be no Safe and Calm webinar for next Wednesday, October 7th. We will be convening on Friday, October 2, and then again on Friday, October 9th. Just to send out a reminder about that, we will put that in one of our updates. So our agenda today will start with our usual advocacy update, focusing on a very short discussion about the budget and where it's at, several pieces of pertinent legislation. We'll have a very brief COVID situation update, and then we'll be reviewing testing guidance for both HFAs and nursing homes, since there have been some recent changes and questions about that. We're going to end the webinar with nursing home specific content, and we are pleased to let you know that we have Margaret Chamberlain with us this morning from Ralph Law, and she's going to be discussing some of the trends in infection control citations. So with that, we will turn the presentation over to Dalton Herbal, our Director for Public Policy, for the advocacy update.
Good morning, everyone, and welcome to the call. As Deanna said, we'll be doing a brief budget update, kind of where that is at in the process, because I think following that is very interesting and important to know what the process is like and how that process happens. So when you hear something like, let's say the direct care worker payments have been extended for 3 months, how that actually will be implemented. We'll also be touching on some PACE legislation that has been moving, and then the electronic monitoring and SNFs bill has reared its head again. So I'd like to take some time to ask the same survey questions I asked when this came up originally in March, since we've been through a lot together since then. And then also just some brief information that kind of shows you where the state's head is at, that the field hospitals have been renewed, the leases, that is, have been renewed for those field hospitals in Novi and Detroit. So firstly, we'll be touching on the budget bill. The budget bill was reported from the legislature on Monday, which means that the bill has been approved by both the House and the Senate, which moves the budget bill to the governor's desk. The governor now has 14 days to sign that bill from Monday, so that would be 12 days left. And because the governor was involved in the development of this budget, we don't expect there to be many changes. Also, they have until October 1st, so we do anticipate them to sign something rather quickly here. And once this bill has been signed, then the programs within the bill can be enacted. So the reason you're not seeing any kind of guidance or notification that from the department that the direct care worker pay has been extended is because the bill isn't law yet. So the department doesn't actually have any instruction to move forward. And so the important part here is that the budget is on the governor's desk and will be moving forward quickly, I certainly hope. An interesting piece of legislation moving away from the budget is the PACE eligible client market size bill, which is SB 810 if you're interested. I included links to the bill language here and also to language from Director Kate Massey that froze the expansion of PACE programs in Michigan. So it's interesting that while the department is saying we can't expand PACE this year because of budget concerns, there are still players working in the legislature to get some things done for PACE because they see future opportunity there. And there are also still some applications in the hopper that are, those applications do not fall within that freeze that Director Massey talked about. Specifically in Southeast Michigan is where they're really focusing, or where those applications are for, kind of the Detroit, Oakland County area. So that's where they're looking to expand another PACE program. So in this bill, it defines PACE eligible client market size as the total number of non-institutionalized individuals reporting a disability over the age of 65 with an income of less than $25,000 as measured by the US Census. And so they're defining what a PACE market, or who applies to a market for PACE. And also in this bill, they also remove the first right of refusal language that PACE programs have. As you know, PACE programs right now are given a zip code or an area to operate in. And existing law says that if a new entity wants to enter the same zip code, the PACE program gets an opportunity to say, hey, we can meet those service needs before the new person can move in and start a PACE program within those zip codes. And so this bill removes that language and it changes it. That says an entity may establish a PACE program in a geographic area already designated to and serving an existing PACE organization should they submit the following information to the department. Documentation demonstrating that an unmet need exists in the area, evidence that the applying entity has relevant experience and financial resources to operate a PACE, evidence that the proposed PACE program will not create an unnecessary duplication of services in that area, evidence that the entity's proposed PACE program will not impair the financial and service viability of other existing PACE programs, and evidence that the total number of potential PACE eligible clients within the service area is greater than 5,000. And then also along with this, it says that MSA shall approve the entity's PACE program within 90 days after receiving an entity's required document. So the players in the PACE world, at least legislatively, are trying to, some of the players, I should say, are trying to open up these more strict zip codes and areas of operation so that they can also establish a PACE program there. But right now, PACE program growth is frozen, except for those who have an application. So it will be interesting to follow this through the process as the kind of thinking around PACE evolves and how they should be able to operate within the state. So we're going to move on to electronic monitoring. I've talked about this a lot on these webinars. I apologize for the duplication of this, but it keeps coming up. We've been having these discussions since January. It came back up in March, and it has come back up again. And this time it does have some legs behind it. And there is some concern that this bill will be used in some kind of a political trade, i.e. we'll pass this bill if you'll pass this other one. So I wrote that the bill is likely to pass Senate Health Policy tomorrow. I mean today. The bill is likely to come out of committee then. Once out of committee, it would move for a vote in the Senate. And it's likely to pass a vote in the Senate, which would then move that bill to the House. We currently don't know the speed that it would move in the House. There is some appetite for this kind of a thing. But once again, what we were initially hearing was that the House was going to move this bill in late December of this year. But now we're hearing that it could be used in a trade. And a new version of the bill came out that is the one that will be reported out of the committee, which we'll be reviewing today, And then I'll be asking the same survey questions I asked in March to see what we think about it as a membership. So at a high level, this bill would allow a resident in a SNF to install an electronic monitoring device in their room. An electronic monitoring device as it currently is in the bill means a camera or other device that captures recordings, broadcasts audio or video, or both. And it's important to note that still photography will not be allowed in these devices. So this is a copy of our testimony, the first bit of testimony we submitted in January. As I said, it's been a very long negotiating process, I'll say. And so we also submitted testimony in March and continue to monitor the bill today. Throughout the process, our testimony has highlighted concerns about residents' rights, specifically decision-making and resident privacy, compliance with HIPAA standards, renewal periods for these devices within a SNF, and giving input into Laura's implementation process of this legislation. We've asked for work groups, task forces, and just a general, more collaborative process with Laura. So what does this bill say in terms of consent and privacy concerns now that the bill has been changed out for a substitute of the bill? If you remember back to March, you'll know that it's very similar to the bill that was in March, but there are some distinct differences. In March, they said that a nursing home could request that a resident make the request that the resident submit a form or application that they would like to be electronically monitored in the room or have this equipment installed. Now it is a must. So the resident or resident representative must file a notification and consent form in writing with a SNF if they want to have an electronic monitoring device in their room. And this notification and consent form will be developed by Laura. And they must get written permission if they have any roommates from those roommates. For a roommate, they must also use that notification and consent form. And the recording device must be turned off if a new roommate moves in and consent has not been given from the new roommate. And a resident or the roommate has the right to set pre-selected conditions or to turn off their camera or monitoring device at any time they so choose. And then once you receive this form, the form must be placed in the resident's clinical record. It's important to note that the recording device consent can be withdrawn at any time from the resident, and that a SNF must post notice on all entrances to the SNF and also on the resident's door that a monitoring device is being used in the building. And all of the recordings from this are the property of the resident, and a SNF can ask, but must pay the costs of acquiring a copy of this, but the resident can refuse. So what are the responsibilities? You'll remember, if you remember from March, these are largely the same, except the internet costs of the device have been added underneath the resident and resident guardian responsibilities. So a resident or resident guardian must pay for all the costs of the electronic monitoring device, including the purchase of the actual device, maintenance costs or the costs to maintain the device, installation costs, activation costs, removal costs, and the cost of internet services for the device. And as a SNF provider, you must provide a place to locate the device and access to a power source. And it's also important to note that a SNF cannot refuse admission of, discharge, or retaliate against a resident based upon their monitoring preferences. So, if you remember back to March, the recording could be used as evidence, and that is still true today with this substitution bill. Recordings are admissible as evidence in civil, criminal, and administrative hearings. This is only if the process has been following. If not, the recordings cannot be used as evidence. They also cannot be used as evidence after 8 years of the initial recording, and all video and audio evidence must include a timestamp on it. And additionally, a SNF is not civilly or criminally liable for the inadvertent or unintentional disclosure of a recording by a resident or a resident's representative. The substitution, a big part of the changes to the substitution bill from the original bill is that it actually puts requirements on what LARA can do when implementing this kind of a policy. It says that the department must look at only these things when implementing a policy. And I've listed them here, all 9 of the things that the department needs to establish, and they cannot go beyond this. So the first one is that they need to provide a procedure and requirements for SNFs for the actual consent form for SNFs. They also need to provide requirements for how to obtain and document resident comprehension for electronic monitoring device purposes, how to obtain consent from a roommate, how to retain and distribute the completed consent form. They also need to identify the standards of reasonable accommodation for installation in SNFs. They need to provide guidance on how to turn off and when to turn off electronic monitoring devices. They need to provide guidance for the consent withdrawal process. They also need to provide guidance for the removal of a device once consent is withdrawn. So once a resident withdraws consent, what is the time frame that you need to follow would be an example. And they also need to provide guidance for what the public signage needs to be. Once again, they cannot go beyond these 9 things when setting up the implementation process. So we're going to move on to a couple poll questions. The first one is to be more broad and just capture how you feel about the potential of residents installing their own electronic monitoring equipment in their room. This is for even if you're not a SNF provider. I know the bill is only for SNF providers, but I am interested just to see how people feel about residents having electronic monitoring equipment in their room.
All right, so I will go ahead and launch that poll right now. So you should see that up on your screen. So we'll take 30, 45 seconds, something like that, allow everybody the time to vote, and then we will see the results from there.
And I'd also like to encourage anyone while we do this, if you have any kind of feedback or anything, you can either email me or call me or provide it in the chat and I'll review that if you have some comments you'd like to make.
All right, so we'll give this another 5-10 seconds and then we'll go ahead and close this. Looks like it's been staying steady. All right, so I'm going to close this one and then we can look at the...
Interesting. So I think on a whole, people are more on the uncomfortable side of the spectrum here. Okay, my second polling question is, how do you feel about the provisions of this bill as I outlined today? 1 is uncomfortable and 5 is comfortable. I know it's kind of a quick turnaround and a lot of information, but I do appreciate any feedback that you could provide.
All right, and we'll give this one another 10 or 15 seconds again here.
Thanks, Blake.
All right, looks like we've been staying at the same number of votes for a little bit, so I'm going to go ahead and close this one, and we will share the results with this.
Okay, so this is actually a little more towards the middle, which is not what I would have expected based upon the last question, but I guess the bill does offer some provider-friendly parts to it. So that's good to know. Thank you all for your feedback. And I do encourage you, if you have any written comments or you want to just call me and talk, please feel free to reach out. We'll move on to the next topic here. As I said before, this is just to let everyone know that the department did renew the leases for preparation of a second wave of COVID. This is the Novi Suburban Collections Showplace field hospital that served, I think, 16 people throughout the first wave of the pandemic. But this time it's reduced in size from 436,000 square feet to 398,000 square feet. They also renewed the lease with Detroit's TCF Center, but there was no reductions in size to that field hospital. Lastly, I did want to provide a reminder, as if you were on Joint Provider, the web call yesterday, they did provide a reminder there, and I thought, hey, everyone deserves a reminder on our call as well. The deadline for the applications for the electronic device CMP application is October 1st. The application is not very long, so I know you only have about less than 24 hours to do it, but if you haven't done this yet, it's a good opportunity for you to get some money to provide electronic devices for digital communication for residents. This is just a copy of a slide from the previous time we talked about this. You submit the application to that email there. The actual application can be found using that link right there. And there's some notes there for a successful application and to move it through the process quickly. But as long as you have something in by October 1, you should be at least considered for the CMP funds.
All right, thank you very much for that, Dalton. Before we get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our annual conference during the Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. All right, so let me pull up the questions here real quick. We had a couple for you. What is your recommendation on how to handle the $2 differential for direct care workers and SNF starting tomorrow?
Well, I am hoping that we will have something tonight, but also I would continue to move forward, as these kind of budget bills are retroactive. So if she does sign the bill, say in 2 days, I know she has more days than that, but if she signs it after tomorrow, those funds will still be there for October, even if she signs it. So I would just say continuing following the process. She's expected to sign it, and this was one of her initiatives herself. So I don't think these funds will be cut. So just continue going as normal and you'll be all set, and follow the same process. I've heard that the exact same process will be used. It's just literally a continuation of the program.
All right. This one's more of just a comment regarding the cameras. We are very concerned about dignity and privacy for the residents if cameras are in place.
Excellent. That is one of the topics we've brought up to legislative members, and they also share those concerns. And also the Ombudsman Office has also testified along with us and shared some of those concerns. So they're certainly hearing those messages.
What will this device do for us? Are you talking about iPad or similar?
If we're talking about the CMP devices, it could be an iPad. Yeah, that's the most common thing. I've heard of people using. On the joint provider call yesterday, it was shared that one of the facilities used the funds to purchase like an electronic cart that they could wheel into rooms and foster communication. But I think the most common thing is purchasing like an iPad so residents can FaceTime, Skype, Zoom, whatever with family members. This CMP fund thing was implemented when visitation was much more restricted than it is now, which is kind of crazy to say that much more restricted visitation than it is now when we can only visit outside with 2 people. But this is kind of where they're coming from. So yes, iPads.
All right, and it looks like we have the last question here. Will the $2 an hour be expanded to employees of SNFs who may be labeled dietary but are in indirect contact with residents?
Unfortunately, no. The $2 an hour payment program is remaining the exact same. The funds are just an extension of the program, not an extension or expansion of the program. So it's for the exact same qualified individuals as it was last time.
All right, sounds good. Thank you for all of that, Dalton. It looks like that was the last question, so we can go ahead and move on, Deanna.
Okay, thank you, Dalton. We have a very brief situation update this morning, mostly just to clarify some issues in terms of the nursing home data and some reporting. So we're going to move directly to our routine graph that displays the 7-day rolling average of Michigan daily new cases. And you can see that we've had an upswing occurring mostly over the last weekend, with cases breaking over 900 for 3 days in a row. While we can still see some fluctuation here, it does appear still fairly stable over time. But we're going to have to monitor this closely as we approach the fall, and be aware that cases are growing in other states currently as well. The next graph demonstrates our 7-day rolling average of Michigan daily deaths, and they seem to be holding fairly steady. Excuse me. This is a display, actually it's a screenshot of the CMS positivity rates for Michigan counties. And this applies to nursing home testing requirements by CMS. And if you remember, on Friday, we had a brief discussion about the fact that CMS can adjust the ranking of the test positivity rate when there's not been enough testing in a given county to make that meaningful. So what they stated was that facilities should go by the county code color instead of the actual number. And I thought they were referring to a map. I couldn't find the map, but a brilliant member helped me out here. And this is the color code system that they're referring to. So the point is that you should pay attention to the green, yellow, or red color codes and not necessarily the number. It's possible for you to have a number that is outside of the range of those color codes if you happen to be in a place where there's been insufficient testing to make the number meaningful. Remember, though, that MDHHS still requires testing weekly across the state. And of course, if a nursing home is in a red area, and we don't have any right now, but they require twice per week testing. As of this past Monday, we had 7 counties over a 5% positivity rate, which increased from 5 last week. However, in looking at Michigan, as I scanned this whole graph, if you look at some of these other states, they are highly yellow and highly red. So when we look at that in comparison to some other states, we're still doing fairly well. And on Monday also, the department issued an updated testing guidance and FAQs. And that testing guidance included the crosswalk from the old risk categories to the new. So you will see that using this new purple map, only the low areas will not have to do weekly testing. And currently there are no low areas in Michigan. So we're going to talk about the testing protocols a little bit more this morning, but we want to take a few moments and talk about the recent executive orders. There's been a lot of confusion around a couple of them. Last evening, of course, as we said, the governor issued 188, which extends the visitation prohibitions for all congregate and long-term care facilities. We were, of course, hoping for news that they were going to start indoor visitation, but apparently the state is still working through that. With the temperatures dropping and outdoor visitation becoming problematic, we are continuing to advocate for a more balanced approach to address the senior issues. Also yesterday, the governor extended the state of emergency to October 29th, which was not really a surprise. On Friday, the the governor issued Executive Order 2020-83. And that order opened up a little bit more the possibility for a little bit larger event and some social gatherings indoors for non-residential settings. There's a lot of safety parameters, but again, this is not meant to apply to congregate living settings because we believe that they are considered residential. So we've received some questions about whether group activities would be allowed here. And they're still prohibited through Executive Order 179 for all entities except independent living. 179 does expire at the end of today, but we believe that it will be extended just as the others have been. Since independent living is not included in 179, those settings are only encouraged to review their policies to avoid unnecessary transmission in their individual community under guidance from the CDC. But in Michigan, there are no requirements to stop residents from gathering as long as social distancing is applied. However, those large event numbers are not necessarily applied here, again, because this is a residential setting. So that hopefully explains most of that. And we can move on. Here is a brief review of the recent HFA guidance from MDHHS. We talked about this about a week or so ago when it came out. Facilities licensed as an HFA can provide certain levels of testing, and the department will reimburse for it. We have had several questions about this guidance, and we forwarded them to the state. And while we have yet to get a response to those, we have talked to the state, and they've shared some concerns that not many HFAs have applied for MDHHS assistance for testing. So note that they will reimburse for testing to diagnose the illness for residents and staff, will allow a one-time baseline test for all residents and staff. They will reimburse for new staff starting to work. What they do not include here is what the nursing homes are doing on a weekly basis. They haven't included any routine screening for staff. They also consider, and this is where a lot of our questions have come up, that they've only considered laboratory and state options for managing the tests. And the guidance is silent on the point of care tests that could be conducted by staff. So although we identified again with the state some of these concerns, they still have not responded. But their issue is that they want to understand better why they haven't gotten requests for state assistance to test. So we told them that we would check in with you all, and to get a little bit more information, we've inserted a few polling questions for HFAs only. So the first question is, are you currently doing any testing? Move the slide, please, Blake. Are you currently doing any COVID testing for staff or residents? Remember, this is for HFAs only, a simple yes or no.
All right, we'll just give this a few more seconds here, and then we will close this out and show the results. So if you haven't voted, go ahead and put your vote in, just a yes or no for this one. All right, so I'm going to go ahead and close this one, and we will share the results for that.
All right, great, 68% doing testing. Okay, wonderful. We'll move on to the next question. The next question is half of a question because we could not get all of the options on in one question using the program that we use. So if you are testing, so this is just for those 68% who said they're currently testing, please identify all the testing protocols currently in your testing plan. And your options for this question is, have you done the one-time baseline testing? Are you doing weekly testing for 14 days following outbreaks? Are you doing testing at the time of admission for new residents? And are you doing testing before new staff start work? So you can put up the poll. Yes, thank you, Blake.
All right, so we'll just give this one another 5 or 10 seconds, and then we'll go ahead and close this out. All right, so we will close this one and share the results for this.
Okay. Time of admission is a big one before new staff. So, okay. Great. Thank you. The next question is some other considerations for testing. And so HFAs who are testing only, are you testing for symptomatic persons, for exposures, and are you doing any routine weekly staff screening?
All right, again, we'll give this about another 10 seconds, so if you haven't voted, go ahead and, well, I guess not voted, but if you have not put in your answers, you can go ahead and do that. All right, and we'll close this one and share those results.
Okay. Okay, great. Okay, a couple of final questions. The next one is about whether or not you plan to request MDHHS reimbursement for testing. One of the things that I thought when we talked to them is that perhaps we just haven't given HFAs enough time, and that many of them are already doing testing on their own and may not need state assistance. So this is for those who are testing or planning to test. Do you think that you're going to be requesting MDHHS reimbursement for testing?
All right, we'll give this one another 5 seconds or so. So if you haven't voted, go ahead and do that, yes or no, and then we'll close that and take a look at the results. All right.
Okay, good. I do think, and I'm not sure about this, I think there's some time considerations for this. So if you are planning and have invoices that can support a a request for funds, I would think that you should do that soon. Last question is about whether or not you plan to contact MDHHS to ask for their testing assistance. The state can come in, bring their own supplies, do the tests themselves. They have contractors that can do that. Sometimes it's the National Guard. Do you plan to do that?
All right, so we'll go ahead and close this one and share those results.
Okay, all right. Well, and I think that that's what the department is wondering about, and we will certainly convey these answers to them in our next discussion. So thank you very much, everyone. Okay, so let's move on to questions so far.
All right. Thank you for that, Deanna, and thank you everybody for answering all the polls there. Before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. All right, so we have a decent list of questions here. I assume we follow the positivity rate for where our SNF is located and not where the team member lives. For example, one of our SNFs is in green, but we have a lot of team members who live in a yellow area that is nearby. Of course, we are following Michigan's weekly guidance for now.
Well, and the yellow area does require weekly testing for both the feds and the state. Actually, the CMS does recommend that you look at adjacent counties, and then if you're pulling from an adjacent area with a different test positivity rate, you are supposed to look at that in determining how often you need to test. So if you were next to like a red county, you would have to probably up your testing frequency in relation to that if you are pulling staff from that area.
Okay. I read Executive Order 188 and did not see when the new EO expires. Did you see a date when you reviewed it?
I have to go back and remember which one is 188.
I believe it's the visitation restrictions, I think.
I could not find a end date to the visitation restriction guidance this time, which I'm not sure what that means, but the visitation guidance itself, I could not find an end date.
Yeah, we had about 3 or 4 questions about that. What is different about gathering for group activities, dining, and visitors and independent living as it compared to skilled and assisted living?
Well, the only requirements for independent living and other apartment-like settings for seniors, etc., is that visitation is closed and you have to screen everyone. The requirements for no group activities or no communal dining, etc., do not exist for them, at least not in Michigan. The CDC does recommend highly that you look at your community transmission rate and you make your decisions about how to mitigate your risk based on what's happening in your community and consider closing or at least applying some safety precautions to those activities on your own. But you are not required to say stop communal dining in independent living settings, although you are strongly encouraged, well, you have to apply social distancing and masking when appropriate, but limitations and restrictions are not required, but highly recommended by the CDC.
Okay. One of the points is weekly testing until 14 days following any outbreaks. If 14 days have passed, are SNFs still required to do weekly testing?
Well, yes, you are, but only because, and just for staff, not for residents. The outbreak requires that you do residents and staff until there are no further outbreaks for 14 days. The weekly testing requirement continues for staffing beyond that, simply because the state is in a high enough transmission level to warrant that right now. But no, if you actually end up, or we get to a place where that weekly staff requirement isn't there, you could stop testing after 14 days after the outbreak.
Okay. Any thoughts on why there was no end date provided on EO 188?
No, it could be good, it could be bad. I was thinking for a moment it might be a good thing. Maybe they don't want to give an end date because they plan on changing it soon. And then I thought maybe they didn't give us an end date because they don't plan to change it soon. I really have had no idea. We've not had a discussion with the state about that since it came out.
Okay. The MDHHS AL testing guidance from 9/15 says for those who refuse testing, you must have a plan, but doesn't specify. Your slide said to follow the NH guidance for refusals. Can you confirm if this is what we must do?
Yes. Remembering, though, that all of the requirements for testing are recommendations in Michigan for anything other than nursing homes. But yes, the guidance specifically says, please follow the nursing home protocols for residents who are refusing.
Okay. I think it will take more time on reimbursement for HFA testing, as you can only request reimbursement once insurances pay first, if there is insurance, so it is more of a process.
Yes, and I agree with you. I think that they perhaps were anticipating a little bit more quicker implementation, but I think they also were looking more toward why hadn't they gotten more requests to help. But we will be providing all of that information back to the department.
How do you get clarification on executive orders? Do you have a contact person with whom you can quickly communicate?
Executive orders are hard. It is not as easy because there's multiple departments involved, and we often get differing explanations from many different departments. There is no one single person I know of. There might be other people at Leading Age that might be aware of one single person that we could talk to, but I am not aware of that. I mostly talk to the department, MDHHS, and sometimes Laura.
We still have no guidance on HFA waiver facilities on dining programming.
That's true. We do not.
Okay. How about allowing independent living residents to go out without quarantining for 14 days? Can independent living residents have visitors with social distancing and masks?
Okay. I want to make sure I have that question. Can you repeat it, please?
Yep, that's fine. How about allowing independent living residents to go out without quarantining for 14 days? Can independent living residents have visitors with social distancing and masks?
Okay, there's no requirement that independent living persons be quarantined if they simply leave the building. There are some people who are quarantining people. Some independent living facilities are quarantining people when they come back from a hospital for 14 days. But there's actually no specific guidance that says they have to do that. In terms of letting people come visit, no, visitation is still not allowed inside the facility. Outside visitation is allowed at this point, except for those few exceptions that are listed in the epidemic order of, I think, most recently, I don't remember the date, but except as those exceptions for compassionate care and ADL assistance, etc.
Okay. In IL, group activities are allowed. We are a faith-based facility and our residents are wanting Mass. Can we allow a priest to come into the facility? We do not allow anyone but residents living in-house to attend Mass.
I believe if we go back to the guidance that certain service providers, including clergy, could be allowed, but I think that they recommended that clergy be allowed to communicate electronically if possible. I don't think that because of the definition of service providers, I do think that if you didn't have any other alternatives, a clergy person would be appropriate.
Okay. What about Executive Order 179? It's set to expire today.
Right. We expect that it's going to be extended. We've not heard from the department.
Is Michigan going to align with CMS directives regarding visitation? We continue to be placed in the middle, and CMS has been very clear about this.
Yes, we know. The state has not really offered a lot of information about their planning for this, although we have had a couple discussions. They keep telling us that they're considering it. So we're still waiting for their response. We have not heard anything really from CMS other than the fact that they plan to work with the state to get everything in alignment. So we're all kind of still lingering out there waiting for an answer.
For those that refuse testing, what is NH guidance say for employees?
I'm sorry, say that again, Blake?
For those that refuse testing, what is the nursing home guidance say for employees?
Let's hold on that question because I'm going to go through the guidance in a second.
Okay. I thought clergy were a non-medical service providers and MD-HHS order.
Yes. That's what I meant to say if I didn't say that clearly.
All right.
I think, Blake, that we need to move on.
Yeah, that was the last question, actually, so we are good to go.
Okay, good. Let's move quickly on. So one of the things that I want to talk about today is the updated financial guidance for nursing home testing. You can move the slide forward, Blake. A summary and a link are provided here. The change to this guidance is really the inclusion of point of care tests into the reimbursement plan, and that the state will reimburse these costs as well as for other tests, just like other tests, including buying additional test kits and specimen collection fees. They had assured us that they would cover these things, but now it's in writing. So also last Friday, they updated the testing FAQs for nursing homes. And they also suggested that since they had made so many changes, that facilities review the entire piece. We have pretty much listed all the major elements on the next slides, but we'll only be going over the changes or significant areas this morning. So the first slide doesn't really have any of the changed language. Go back. But they do clarify that the list of laboratories that they provide for nursing homes is not all inclusive. These are only the big labs who have a lot of capacity, and other labs can be used if they work with Medicare and Medicaid and meet all the other requirements. So this is the place where they put the crosswalk for the risk levels that we discussed earlier, and as far as we can tell, the FAQs is the only place where they've issued this crosswalk. So, you know, it is good to review the whole FAQ if you have a chance to do that. One of the questions has to do with the frequency of testing and the reimbursement for it. And their response is if you are in a CMS red area, which means that you your test positivity rates are over 10%, you must conduct twice weekly testing, and MDHHS will reimburse for it, even though that frequent testing exceeds the Michigan requirements. Next slide. This slide includes just a slight change in some of the language. Facilities are required to test any new or returning resident on admission unless tested within the past 72 hours. And that doesn't mean that you have 72 hours to complete the test. Some facilities still misinterpret that. However, obviously you do not need to retest anyone who has been PCR positive in the past 3 months. They have refined the statements about contractors. That's what's highlighted on this slide. They encourage all contractors to be tested who are in the building on any kind of routine basis, but they are only requiring weekly testing for those who are in the building for a minimum of 8 hours per week and who have direct resident contact. And of course, the definitions for direct resident contact are here, but they have not changed. Whether using either point of care or PCR testing, the state guidelines require a clinician order, even though at one of our recent conferences, the Bureau stated that an order was not needed. MDHHS is requiring it for all testing. However, the waiver is still in place that allows nurses and other physician extenders to order these tests as needed. The department has also updated its program to assist in emergency staffing situations. They will provide some emergency services for a bit longer period and for more situations. And the link to that new guidance is on the slide and in the FAQ. So one of the questions that keeps coming up is the need to conduct the outbreak protocol. Immediate testing of all staff and residents with other, along with other precautions. If a staff member contracts the illness outside of a facility. So the idea is that because facilities do not have to test for non-facility acquired residents, why would they have to test if they believe that a staff member acquired the infection outside of the facility? But you can't think about it that way because the staff has been working in the facility. So if any staff member ever contracts the illness, it does count as an outbreak, no matter where you think that they've gotten it. If they you have to start the outbreak protocol. But if a staff member does get the virus, but hasn't worked in the facility for a minimum of 48 hours prior to any symptoms, you don't have to initiate the outbreak protocol. This updated guidance makes it clear, the FAQs make it clear that antigen tests are allowed to be used in compliance with the order. And the FAQs continue to say that testing in medium or higher regions and in nursing homes should be considered in view of the high risk for transmission. And what that means is that they should consider all the positives as really positive, even though we know that there have been some false positives in point of care testing. And facilities will be reimbursed for point of care tests for staff, private pay residents, and Medicare Part A stays at full lab cost. Otherwise, in order to get reimbursement, facilities will have to bill Medicare B and Medicaid. And the state will reimburse for collection costs no matter who the payer is. That is a given. Now on to a few last updates. Nursing facilities now have access to their confidential draft report for the new quality measure called Healthcare-Associated Infections Resulting in Hospitalizations. CMS considers many of these infections as preventable, and the resulting hospitalization is preventable. But these are not considered never events. So the measure is intended to compare performance against other providers, and it's also risk adjusted. So anyway, these reports are available in Casper, and these are claims-based measures, and individual SNFs can look at them. I think they're out now. NHSN is encouraging facilities to report their influenza vaccination data, but there's no requirement at this point for nursing facilities to do that. There are 2 webinars about this coming up, October 1, October 6, and the links are here for anybody who might be interested in that. And the CDC with NHSN has created a new reporting pathway specific for point of care testing. So such testing is going to require an upgrade to something called SAMS level 3, I believe, in facility access level. So more information is going to be coming out about that. They plan to release the new pathway around mid-October. And any nursing home that would like to upgrade now can email NHSN at CDC in order to get information about how to do that. And lastly, very quickly, AHRQ, the Agency for Healthcare Research and Quality, has just yesterday issued a notice about a new program through Project ECHO. ECHO itself is a collaboration between local hospitals and clusters of nursing homes with the idea to share information and guidance. This program specifically creates an action network of homes that can receive free training and mentorship. There is a 16-week training program, and 3 staff must attend at least 13 of the meetings in order to receive a $6,000 stipend. There's also an option for a 36-week period with assistance in implementing some of the changes. So the link to sign up is here, and if you need more information, that link will get you there as well. So we're going to conclude today. We're running a little late, so we will conclude today with a brief summary of nursing home infection control issues as discussed by our longtime friend, Margaret Chamberlain, who is with Rolf Law. Welcome, Margaret.
Good morning. So I was asked by Deanna to pull together some of the issues that we've been seeing in the infection control surveys. A lot of my clients, Michigan actually was getting a lot of these infection control surveys earlier, I think, than some of the other states. But you know, over the course of the past few months, we've seen quite a few repeat citations and some patterns developing. The first one that we've been seeing are citations on cohorting, and I don't think that should come as a surprise because this is an area that I think Deanna has, I don't know if we spoke about it today, but this has certainly been something that we've been talking about, cohorting new admissions and readmissions and what that involves. I've seen a lot of citations on that. The real issue is whether facilities can cohort new admissions and readmissions in single rooms or if it has to be in a specific area of the building. A lot of immediate jeopardies for this issue. And it's my understanding, because that's inconsistent with what CDC has written, that it can be in an area of the building and or in a private room. And I think we're going to see some movement on that from the department. This is an interpretive issue. And it's my understanding that we're going to see some movement on that. I'm not sure, we were talking a little bit about this before this presentation about what that's going to mean for providers if they're going to have to, if the department is automatically going to go back and revisit those, if they change their their interpretation of this, or if the facilities who have been cited for this are going to have to approach the department on perhaps, because there's going to be no mechanism. The IDR process would have been over. And so are we going to have to approach the department on changing those citations? More to come on that issue, however. The other issue is on dialysis and residents going out for dialysis and residents for physician visits. I've seen immediate jeopardies on this specific issue. Do the residents on dialysis who are leaving the facility for dialysis or going out for physician visits have to be treated as new admits or readmits in terms of moving into an observation area? And even though CMS has specifically said there is no direction on this, the CDC has not provided any direction on this. The state has interpreted this as facilities have to keep their dialysis patients and residents returning from physician visits in either a specific area or in a private room. So treated much the same as new admissions and readmissions. And the language that they use, they call those observations as opposed to quarantine. So the next area that I've been seeing a lot of citations is with respect to screening. It's low-hanging fruit, in my opinion, for surveyors. You know, you get these big citations for things like cohorting or things that are large issues for surveyors, but then there's a lot of low-hanging fruits that they can, add in, throwing things at the wall to give a citation for. Screening is one of those. If there's holes in your in the forms that you're using for screening visitors or staff, that is a pretty simple thing for the surveyors to cite you for. One of the interesting things I saw recently is the surveyors themselves intentionally not completing the forms when coming into the building, or not completing them completely. And when brought to their attention, them saying, I did that on purpose. And so I don't know if this is a new tactic that's being used to see how good the oversight process is for the facility. Like, is the person who's checking people in, are they doing this consistently? But I do think this puts facilities into a bad position, because then you're essentially being asked to confront a surveyor on their failure to comply with your policies. And I can see this extending to potentially their use of their inappropriate use of PPE potentially, or some other policy that they're failing to follow. And so I think there's going to be more to follow on that particular issue as well. But screening in general, that is low-hanging fruit. It's my advice on there is just to be conducting regular audits to make sure that you don't have holes and that you do have somebody who's has good oversight over that screening process. Of course, another big issue is the use of PPE. That's almost on every infection control survey that I've seen, that you have PPE that's not being worn appropriately. You've got the mask under the nose. You're not washing your hands for a full 20 seconds. The typical things that it's, I feel bad for our employees, because this is such a, it's exhausting. And it's so easy to, make a small mistake, like pulling your mask down, somebody being seen touching the mask, little things like that. I can't overemphasize how easy that is to throw things into a 2567 and make it difficult to do anything about that. One of the issues that I've seen developing in other, I haven't seen it here in Michigan, but I am concerned about it coming into this area, is a fixation on the use of N95s. I think for the most part, I haven't heard that my clients are having difficulty in obtaining N95s, but they are required for use in COVID positive and for those new admissions and readmissions people in that observation area. And it's, so they're focusing on if you have N95s in the or if you have N95s in your building, you have to use N95s before you use any other substitute. And if you don't have N95s and you're using some substitute like KN95s, you better make sure that they are not on the list of unapproved KN95s, and also that you thoroughly document your efforts to obtain N95s. This has been a hot issue in Ohio recently, so something just to keep in the back of your mind. Another area that we've been seeing here in Michigan is the sanitizing of equipment, both shared equipment that you're using between residents, and also sanitizing, things like the face shields and goggles. And so that's another, in my opinion, low-hanging fruit. That is something that in the repetitive nature of, what your staff does in the building, that it's an easy thing to forget about. But it's also a simple thing for the surveyors to cite you on. Another issue that we've been identifying is orders for isolation and observation. It seems that it's insufficient, even if you have a process that is in place that shows that you actually have residents in appropriate isolation and using the appropriate PPE. They want to see the orders for that, even if it's for, even if somebody is not COVID positive, but they're in observation because they're new admission or readmission, or they're one of your residents that goes out for dialysis or has had a physician visit. They want to see an order for that period of time that they're going to be in isolation. And in addition, they want to see that on the care plan. So again, even if you have everybody using the appropriate PPE and appropriate isolation, they're still citing facilities for not having either the order or something in the care plan for that. One of the other things that I've been seeing is the tracking of the actual infection control tracking process. So for your line listing, I've seen issues where facilities are, the surveyors just don't like the way that it's being done in the facility. Even when you've had multiple infection control surveys and you've had no issue with it, then one surveyor will come along that decides, oh, I don't like this particular tracking that this facility is doing, and so I'm going to give them an immediate jeopardy. There have got to be some best practices out there for how that's being done, and integrating the COVID tracking along with your general infection control tracking, so that we can have something that everybody's going to like, because this is a difficult thing, especially when you've had facilities that have gone through multiple surveys where it's fine, and then all of a sudden it's not, and I don't have a really good reason for that citation. But I've seen this on multiple occasions. And then one of the last things I would like to talk about is, again, not something that I've seen a lot of here in Michigan, but I'm seeing in other areas, and I'm worried about it moving into Michigan, which is contact tracing. So when you have a positive in the building, is looking at what was the facility's process for identifying potentially affected residents or staff. What is your process for testing? What is your process for example, if a staff member has tested positive, what is your process for going back and ensuring that people that they've worked with are put into observation, isolation, and testing of those residents? And again, I haven't seen a lot of that in Michigan, but I have seen that in a growing sense in other areas of the country. So that's my synopsis of what I've been seeing from a regulatory standpoint with the infection control surveys.
Well, thank you, Margaret. Let's go on to questions then, Blake, please.
All right. I wasn't sure how you wanted to handle these. We do have quite a list of questions again. And it's kind of a mix, I would say, for Deanna and Margaret. I think there's kind of a mix. So
If you don't mind, I need to make a statement too.
All right, go for it first, Dalton.
All right. So I've been receiving some comments, still with some confusion around this direct care worker funds. Right now, the bill is on the governor's desk and has not been signed. So it's not a guarantee that these funds will be there to reimburse you for this $2 an hour as of right now. She could sign the bill later today and those funds will be there. But it is still right now a judgment call of what you think. And from everything we've been hearing, do believe she will sign the bill and those funds will be there for us. But right now it is kind of a judgment call. And you can move forward either way. It's just, I don't want to make it seem like those funds are a guaranteed thing right now. We believe they are, and everything we're hearing says, yes, they will be, but they're not 100%. That's all.
All right, thank you for that, Dalton. And also, before we get into any questions, I just want to give everybody a quick reminder that we will be holding our AL HFA Day this upcoming, I believe it's next Wednesday, October 7th. So you can go ahead and hop on the Leading Age Michigan website and click on the events tab. That will bring you to our calendar. And we have our AL HFA Day, like I said, coming up next Wednesday, October 7th. And we also have our SNF Regulatory Day, which is going to be held Thursday, October 22nd, and registration is open for that, so you can register for that as well. All right, so now we will get to questions. Can we bill Medicare, Medicaid for a collection fee if we are doing this internally?
No, the idea is that you bill MDHHS for all of those fees, no matter what the payer.
Okay. Forewarning, this is a decently long question, so there's a lot to it. For nursing homes, would it be adequate to monitor residents that go out for necessary appointments for 14 days after return and pull a curtain in a shared room? We are also testing these residents after their appointments on return and on next staff testing cycle. For dialysis residents, we are doing weekly testing. For all of these residents' appointments dialysis, they are wearing masks in common areas for 14 days after their return. We are very limited in private rooms. Do you think these processes will be adequate for surveyors? Also, is there further info on Laura/BCHSS draft becoming active, or any further clear guidance for those going out for appointments, dialysis, etc. upon their return?
Margaret, do you want to take that or do you want me to?
Yeah, I'll take a start, and then if you want to add something, I welcome that. So,
Okay.
With respect to the people going out for dialysis, or those individuals that we're talking about that have to be quarantined, or not quarantined, I'm sorry, under observation for 14 days because they're going out of the building and coming back, either admissions or readmissions, I have had facilities cited if they're in semi-private rooms and they're at the immediate jeopardy level because they're not, even with a curtain pulled, they either have to be in a private room or in a separate section of the building. Especially, I'm talking about if their roommate is not someone who is going out and coming back, because they're viewing that as an unknown, even though there's no direction from CMS on that. And then what was the second part of that question?
Okay, let me find it.
It was about whether or not we expect that to change with the other guidance. And we have heard from the Bureau that they do plan to issue a much updated version, a little bit more clear version of that guidance. So we do expect that to change in the near future.
Yeah, there's not, even the first version of that guidance was a little bit unclear, but they are viewing, despite the fact that there is no guidance in the CDC about how to manage the dialysis residents or the residents going out for physician visits, they the state of Michigan, they are treating them as essentially an admission or a readmission. And so they have to be in that observation period for 14 days. And mixing them with people who are not in that observation period would be unacceptable to the surveyors. I can definitively say that. So in the same room would be unacceptable.
All right,
If
thank
I'm
you.
understanding the question.
Thank you for that. So I think that clarifies a few questions because I believe we had a few people asking about appointments and people coming back and quarantining. So that is good. Can you repeat if the staff haven't worked in 48 hours and the outbreak protocol?
If the staff have not worked since 48 hours before they have symptoms, then you do not have to apply what I call the outbreak protocol, which means that you have to test everyone immediately, identify contacts and possible exposures, and treat them accordingly. You don't have to do that if that person hasn't been on site for at least 48 hours before they had symptoms and forward.
Okay. A specific area, can you define this a bit more? Is a dialysis patient required to remain in their rooms upon return? This just seems to be border on the abuse of isolation. Can you shed some light? I guess that we kind of answered that.
Yeah, I can start with that. I agree. It is, which is why when I initially got when I was seeing these citations pop up over and over again, that's why I spoke to the Laura about it. And then when I was unhappy with the answer to it, I went directly to CMS about it. And I still have no definitive answer. That I was told, you're right, there is nothing in the guidance about that. Here are some slides to read that had nothing to do with the question that I asked. I agree that it is, that means that people in dialysis are permanently in some observation state where you have to wear full PPE, and they are isolated. And so I don't have an answer to that. There's an expectation that they're going to be treated as an unknown COVID. And so they're going to be treated as, if you're letting them out, moving about the building, that's going to be a problem.
I don't remember the details of the most recent draft of the new guidance, though I do think that this is addressed at least a little bit better in the upcoming documents that are expected to be coming out, but we would have to wait to see, because right now they're going to cite you.
Yeah.
Okay. Clarification, SNFs can also bill for the resident specimen collection reimbursement as well as staff specimen collection reimbursement for COVID-19 testing?
Yes. Any collection that you do is billable to MDHHS.
Okay. Are there any changes with CDC with the N95 masks?
Margaret, you were talking about N95s today, so I think, do you want to take that, or at least to start?
Yeah, I don't know, and I'm not sure what that means, any changes with respect to N95 masks, except for that they are considered the gold standard for what you're supposed to be using if you have COVID positive or unknown. Anybody who is in isolation or in observation, you should be using N95s, period, as your first choice. If you don't have N95s, you need to have an explanation for why you don't have them and be able to demonstrate the efforts that you've made to try to get them. And if you have any N95s in your building, you better use those before even as it was described to me, even if you have one in your building, you better use that one before you move on to using something else, such as KN95s. And then, initially when this started, there was a lot of loosening of what is acceptable for a KN95. There were a lot of companies that were on the approved list, and over time those have been whittled down to where there's maybe like 13 now. And if you are using KN95s, they better be from one of those approved companies. Even if you have, you know, $1 million worth of KN95s from one of those unapproved companies, you can no longer use those as a replacement for your N95s.
Okay. Are facilities being cited for not wearing N95s during regular care or only when not being worn in observation or COVID positive areas?
Only when in areas where they should, not for non-COVID and not for non-observation. I mean, for the non-COVID population, you do not have to wear the N95s, but unless there's an outbreak. But
Okay.
no.
Do you feel the same is true for KN95s and N95s for HFA?
I don't know that there's that same directive or that same oversight. And Deanna, do you have any better sense of that?
Well, the CDC recommends the same protocols for nursing homes and for long-term care facilities as nursing homes. So the recommendation would be there, but there are no requirements for that. So now, if you have a COVID positive resident, I would certainly be trying to use an N95 for that, because it's still not 100% clear that this is only transmitted through droplets. There are some considerations that it could be airborne. And so N95s are an appropriate protection.
Right. Yeah, and it's not just a protection of the residents, it's a protection of the staff as well. So.
Okay. To use N95s, don't you need to get them fit tested? And do you have any resources on how to accomplish if it's required?
Yes, you have to get them fit tested, and there are a lot of resources. And if you shoot me an email, or I will try in our next call to identify those resources for you. A lot of FDA and OSHA guidance.
Okay. And then I just switched the slide over. So if you do need to email Deanna or have any questions, her email is up right there. Sorry, I'm trying to go through these. Is there something in writing that says post-appointment can return to their own private room? We were previously told they had to go to a separate area.
Hopefully that will be coming in writing. That's the discussion that we were having about those observation residents where Michigan has been citing for not moving people into a specific isolated area. But hopefully the guidance will reflect that it's an area or a private room.
Okay.
And the CDC actually says that. It's just Michigan has not been interpreting it that way.
What if you have a COVID positive individual in a SNF and they are being transferred out of the building? Is that SNF required to use N95 masks?
If you have people under observation, that would be considered an outbreak, I would believe. Is that right, Deanna?
Right. If you have someone who's acquired a COVID in your building, that's an outbreak. Even if you transfer them out, you still have to go through the outbreak protocol. Right. And while you're caring for that resident, you certainly need to use an N95 mask.
Right. And so the individuals that would be under as potential exposure to that resident would definitely have to use, and people who have cared for that resident would definitely have to use the N95s as part of the protocol.
All right. So it looks like that was the last question, I believe. It looks like we had a few. Oh, we just had one. What do you suggest if we are at full census and a resident goes out for an appointment and there is not a private room to put them in?
I don't have any suggestions for that. That's been the dilemma that we keep talking to the state about on an ongoing basis, that especially in facilities with high occupancy, there isn't the option to do some of these things that they want to do, especially when there is no active infection or even a suspected infection. I do believe that the guidance is going to help with this when it comes out. So I would have to defer to that in terms of solving that problem. I do think that someone asked me earlier that about staff who decline testing under the FAQ. So I want to get to that just for a moment because it is in the slides, but I didn't go over it. But staff with symptoms who decline testing have to be excluded from work immediately, and they can only return when they meet the return to work guidance criteria and in alignment with what your internal policies and procedures might be. If staff are asymptomatic, if you can do a work reassignment where there's no direct resident contact, that will work. But also you need to consider what to do with that person based on your own policies and procedures. Some facilities do require testing, and you do have the right to do that as long as you obey all the other rules, such as the ADA rules, etc. But you do have to have a procedure for addressing test refusals, both for staff and residents, and I hope that answers that question. So, Blake, anything else?
No, it looks like that was the last question. So if anybody does have anything else that pops up, feel free to shoot an email over to Dalton, Deanna, or the Safe and Calm. And if you think of something for Margaret, again, you can probably email Deanna and she will get you in touch with Margaret and make sure you get any questions answered. So obviously, again, we do have our AL HFA Day coming up, so go ahead and register for that, as well as our SNF Regulatory Day. And now we would like to thank, obviously, Margaret, thank you very much for joining us today. And then thank you to Deanna and Dalton, as always, for everything and all the information. We would also like to thank, I believe we had around 95 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. We do have our next Safe and Calm webinar coming up this Friday at 11 a.m. Eastern Standard Time, so we will see you guys all then, and I hope everyone has a great rest of their Wednesday. Thank you.
Have a great day,
Thank you, everyone. Bye.